session. So welcome. Okay, so tonight's session is one of the Demystifying Dementia sessions that we've been running over the last couple of months, and we're going to be focusing on mild cognitive impairment tonight. Before we start, I will just like to acknowledge the traditional custodians of the lands on which we meet across both these regions today, and pay my respects to elders past, present and emerging. Just a little bit of kind of housekeeping. If you could just add your names to the full profile, that would be fantastic. We'd really encourage you to use the Q&A function to pop in your questions, and they will be answered by our speakers tonight. The session will be recorded, and we would really like to encourage you to complete the evaluation, because that really helps support what we can do in the future. The learning outcomes of the session, I've just popped these up here, and I'm sure our speakers will delve more into that. But these are the things we will be covering.
Kim, I can't see your slides. Are you sharing your screen?
Yes, I am.
Can you see them, Pete?
No, we can't see them.
Okay, well, I just might continue through, and we can put these slides up, because the most important thing is that we get to the speakers tonight. Just encouraging people, and I can put these slides up later, to log on to your local health pathways site. There's a lot of dementia-related pathways in those sites, which will help support that. Okay, so I'm going to hand you over to Dr. Stephanie Daly and Dr. Peter Silberberg, who'll be running the session tonight, and look forward to hearing what they have to say. Thank you.
Thank you. Okay, so hopefully you can all see my slides now. So welcome everyone. Tonight we're going to be talking about mild cognitive impairment in primary care. As you just heard, I'm Dr. Steph Daly. I am a GP based in Adelaide, and I work for Dementia Training Australia as one of the GP education team. And I have with me today Pete Silberberg. Pete, where are you?
Hi, Steph. I'm in the northern part of the state, just a little bit outside Byron Bay, where it's been very wet and rainy.
Has it?
It has.
We haven't had any rain down in Adelaide, so but then we are in a desert. So as the dementia training team, we would also like to acknowledge the traditional custodians of the lands on which we meet today. And as Pete and I are in different lands, I'd like to pay my respects to the Kaurna people of Adelaide, the Adelaide Plains, where I am right now, and also pay respects to any elders past, present, and extend that respect to any First Nations people who are present today. And Pete, I know you're on a different country up where you are in northern New South Wales.
Yeah, I'm on Bundjalung land up here, so beautiful part of the world. Also pay my respects to the elders of this region and any Aboriginal people attending the meeting tonight.
So our learning outcomes today, we're going to talk to you a little bit about the characteristics of mild cognitive impairment. We're not going to delve too much into dementia. There were a couple of sessions done earlier on in this sort of mini series, and I think, as you gathered, these have been recorded, so you can probably go back and have a look at those recordings. The last two sessions actually took you step by step through the process of making a diagnosis of dementia in primary care. But we're going to have a look at mild cognitive impairment tonight, which is kind of the step before that. We're also going to talk to you a little bit about the management and risk reduction strategies that you can use when looking after people with mild cognitive impairment in general practice. So the learning outcomes are one thing, but Pete, we also have some take-home messages, don't we? So do you want to, they're obviously the most important things. Do you want to tell us about those tonight?
Yeah. And just before I do that, just to let everyone know that if you'd like to ask questions during the webinar, we're happy to take questions as we go along. And we've been advised it's best if you use the Q&A box. I think we've got a relatively small group tonight. I can see about 18 people online. So that's a really good opportunity for you to ask questions as you go along. Steph and I are happy to make this interactive. So the take-home messages we'd really like you to walk away with at the end of the hour is that there's this relatively new term that's called mild cognitive impairment, which is another descriptor of people who have a form of cognitive impairment. And we'll go into a bit more detail about what that actually means. But if you have this condition, then 10 to 15% of people each year may have a form of a pre-dementia syndrome. So they may go on to progress to have a dementia. But that doesn't mean there's nothing you can do in this population. Like in those, even with the diagnosis of dementia, there are many things you can do to assist these people and slow progression. And an early diagnosis of cognitive impairment makes a big difference to people's lives. And the other thing is to remember that 60% of people will either get better or remain the same with this condition, which is another important message to be able to give your patients, that if you do have this diagnosis, that not everyone, in fact, it's the smaller number of people will progress on to having a dementia.
So just to give you some framework to have a think about how common these sorts of things are, we thought we'd give you some statistics. So currently in Australia, dementia is the leading cause of burden of disease for women. And it's also the leading cause of death for women in Australia. So it's the leading cause of burden of disease for everyone over 65, men and women, but the leading cause of death for women. And it affects about 1 in 12 Australians in the current population. And that equates to about 400,000 people. And of those people, there's probably about 1 million carers. Now, that number is set to increase to about 800,000 by 2050. But if we look at the population who are living with mild cognitive impairment, that's still a fair size of people. In fact, somewhere between 12 and 18% of the population over 60 are living with mild cognitive impairment. And as Pete just said, a proportion of those people will go on to develop dementia each year. So it's really important that we're looking out for the symptoms of mild cognitive impairment so that we can identify it and support people with those symptoms and help them to live as good a quality of life as possible. So what's our definition of mild cognitive impairment? What are we thinking about, Pete, when we're thinking about how to describe mild cognitive impairment?
Yeah, well, so in brief, it describes a condition where you have a change in cognition. And these changes can be memory, but they can be other forms of cognitive change too, and we'll revise that for you briefly. And these changes are objective. So they're not just the person saying, oh, I feel like my memory is not as good as it used to be, but there's actually objective evidence. So that means that it's also coming from what we call a collateral history. So someone else, apart from the person, is giving the same information, or it might be that you've picked up some changes in cognition by doing a cognitive assessment. And the most important thing to remember next is that the way it differs from a dementia syndrome is that you still have a preserved ability to perform normal daily functions. So you may have some compensatory measures. So the commonest example might be that if your memory was the part of cognition that was affected, if you were still able to go shopping because you'd be writing a list, or if you were still using a diary you'd keep on your fridge to keep track of what you had to do, then they would be considered to be compensatory measures. And as long as you're still able to do the things that you normally want to do and that you were doing in the previous 12 months or so, then that's considered to be preserved function. And that's a big difference between mild cognitive impairment and a dementia, where you have to have a change in function as part of the inclusion criteria to make a diagnosis.
And that change in function is not able to be compensated for, so it's affecting your ability to do your normal tasks of daily living.
Yeah, that's right. And then the word mild, Steph, it's a bit contentious using the word mild especially in a condition that affects people so significantly, isn't it?
It is, because to that individual, the symptoms might not be mild. So I think it's just the way that we have to use this terminology to describe it, but being mindful that it doesn't mean that the symptoms are necessarily mild. It's just describing the type of cognitive impairment, as opposed to it's minor and major neurocognitive disorder, if you look it up in the DSM-5. So they use the term minor rather than mild cognitive impairment. So yeah,
I didn't know that. I thought the DSM was mild as well. So that the DSM uses minor.
minor and major neurocognitive disorders. Yeah.
Oh. So do you know where the term mild is coming from in the Australian context? Do you know why we've chosen that one?
I don't think it's just the Australian context. It's just it's just the old description. I think, like we used to describe, particularly when you're talking about dementia, mild. Even now, it's still described as mild, moderate, and severe in terms of symptomology in the wider community, whereas at DTA we try not to use that language, but it's still something that's commonly used.
Yeah.
So there are two broad types of mild cognitive impairment in terms of the description of the symptoms, and we use these terms, or you may have seen these terms. Sometimes they're written in letters back to us from geriatricians in terms of amnestic and non-amnestic. So Pete, what does that broadly mean?
So amnestic is probably the easiest one, because that's probably one that everyone knows. You know, amnesia is in lack of memory or a disturbance in memory. So an amnestic MCI is where memory decline is the major or the most significant part of the cognitive decline that you find when you're assessing the person. In an Alzheimer's type dementia, not always, but most commonly, memory is the earliest cognitive thing that people notice as well. And so in the amnestic form of MCI, if you are one of those 10 to 15% of people to progress, then it's more likely to be an Alzheimer's type dementia if you're going to progress. And this person may forget, information they previously could recall easily, such as conversations from a few, earlier in the day, or perhaps yesterday or last week, and need to keep, having things repeated for themselves. And then there's the non-amnestic, which means they're experiencing other parts of cognition that aren't memory. And again, we're going to go over this in a second, but these are things like planning, attention, language, decision-making, these kind of things.
And not always, but mostly, somebody with mild cognitive disorder will start by really just having a single domain affected. So usually it's memory that people notice, but otherwise it might be just language. So I had a patient who I was seeing for quite a while, who was primarily had a problem with language. So he had difficulty with word finding, but his memory was intact. So that's an example of the non-amnestic symptoms.
I have to say, Steph, I don't really use those words amnestic and non-amnestic in my own.
No, I don't either. But I think it's important to know that they are existing. Yeah. And as I said, the commonest type of time that you'll see it is probably in a letter back from a specialist. And I think it's helpful to decode exactly what they're talking about.
Yeah, I think that's true. And also, if you go on the Dementia Australia website, they talk about these types of definitions too. And the other thing, it's just a reminder to us that memory is not the only part of cognition that's affected.
But I probably wouldn't use this terminology to if I was making the diagnosis, I wouldn't use this to explain to the patient. I would use memory, more plain language. Yeah.
Can I give you my one last little pet gripe about MCI and the terminology?
Yes.
it's that in the software practice that I use called Best Practice,
yeah, it's not
you
there.
can't actually code for it.
Yes, well, you can. It's convoluted. You have to put cognitive impairment and then tick mild, but it doesn't come up as a true coding, which means that when you're trying to look through your database to see the people that have this diagnosis for follow-up, you can't easily identify them.
Yes, that's right. So DTA, we were going to have yet to do it, but we're going to write to Best Practice to try and get that changed, because it's really important that you need to be able to audit your database. So if any of you out there also do that, then more the merrier. Go for it.
I've heard they're quite receptive to adding in codes, so hopefully they will.
Yeah. So we've had a question, Steph, our first question, and I've got a feeling we might be getting to this, but is there a screening test?
We will be talking about how to do some objective assessments, which is what we call screening tests, because they're not specifically, the tests that we use to assess cognition aren't specifically screening tests, because we shouldn't really be doing them in people who haven't got symptoms, and that's the kind of hallmark of a screening test. It's done in somebody who's asymptomatic and you're trying to pick up disease, but we've kind of renamed them as cognitive assessment tools rather than screening tests, but we will be talking about those. Sure.
Yeah, that's right. And I guess the general principle to Anna Marie, thanks for that question, Anna Marie, is that like Steph said, there is no screening test, whether it be a blood test, an X-ray, or a mini mental state examination type cognitive assessment tool for cognition generally. So whether you're looking for MCI or whether you're looking for dementia, that sort of thing at this stage does not yet exist. There is certainly lots of research and money going in to try and find a blood test that could potentially signify people who might be at higher risk, but we're not there yet, despite lots of money going towards that effort. But it might be close, Steph. We're getting closer, aren't we? And we'll talk a bit about that a bit later.
The gold standard assessment of anybody with cognitive change is making sure that you do a really thorough history and get as much information as you can from the person and somebody close to them. So, but we're going to talk about that as well.
Yeah.
So this is just so you have a little thing in your mind of the different things that you might see predominantly in the aging population, but cognitive impairment and dementia can occur in the under 65. So it's important to broaden it, not just for everyone over the age of 65. But as we know, most people as we age, probably from the age of 40, we do get a slowing of our sort of processing speed, and women will particularly notice that during the menopause they do get some cognitive change, but that tends to normalize over a period of time. But it is normal to have a slowing, I guess, and some memory changes as you age. However, there are a group of people who experience something called subjective cognitive impairment, which is when an individual is really hyper alert to the fact that there are some changes in their memory and can become quite worried by it and quite anxious because of it. But when you see them and you ask questions of their, perhaps, spouse, for example, or child, or you do a cognitive assessment using one of the cognitive assessment tools like a mini mental, you don't actually find any objective changes. So it's purely subjective, purely only noticed by the individual themselves. And this isn't the same as mild cognitive impairment. So it's a separate thing. It's called subjective cognitive impairment. Now, some of those people will go on to develop mild cognitive impairment, and some of them may go on to develop dementia, but it's not necessarily a foregone conclusion that people with subjective cognitive impairment do progress. So this isn't like you move through these stages one by one. This is just to illustrate the various things that we might encounter. Then you have mild cognitive impairment, where there are objective and subjective changes, but their function is preserved. So the individual is functioning in their own environment with the aid of simple tools. And then finally, dementia, which describes a collection of symptoms where the person is struggling to manage their function because of memory and other cognitive change that they're experiencing. So it's one step up from mild cognitive impairment. So Pete, we're going to look at what happens to people who are experiencing mild cognitive impairment on the next graph, and I wondered if you could talk us through it.
This is my favourite slide, probably because a picture tells 1,000 words. I like the one previous, but this is the one that sort of just nails it for people, because we've shown that previous slide in recent education sessions, and the question that comes up that Steph kind of answered is, oh, but not everyone has to progress from normal down to dementia. And of course, that's true. In fact, everything we're doing is trying to slow the progression or help people so that doesn't happen. So this is another way of showing what would happen if you ended up down at the MCI bit. And remember at the beginning, we talked about 10 to 15% of people per year may progress from MCI to dementia. So that's the bottom solid line. And those people would probably say would have like a prodromal phase of dementia. And when you diagnose it as a mild cognitive impairment, they're in that prodromal phase. And then you have some people who just remain stable, and something's happened where their part of their cognition's been affected, and they just kind of sit like that forever, and nothing much else changes. And then there are a lot of people, or a number of people who also improve. So the majority of people either stay the same or improve. And so, you know, think about someone who may be going through a mental health crisis. They might be grieving the death of a relative, or depressed reactive from some other reason. And you would have all seen patients, or maybe even experienced yourself, that when you get very anxious or depressed, particularly your memory and your capacity to maintain attention and lay down memories into your brain isn't as good. And then as you get better from whatever's going on for you, and you go into recovery phase, that attention capacity comes back and you come back to normal. Another sort of short version of a reversible MCI that's not really what you call MCI, but it's a fun one to think about, would be that when you're quite under the influence of alcohol or other drugs, and your cognition is pretty badly affected, you know, during that time, but then the next day, hopefully you make a full recovery. Might take a day or two, but your cognition comes back. So that's another example of a reversible form of cognition.
I have had people I can think of a lady who had a very significant period of her life where she drank a lot of alcohol, so would have been classed as, you know, an alcoholic at that time. And that was maybe for about 4 years. And she's since managed to abstain from alcohol, but the thing that she's been left with is poor memory as a result. But over that, and that was in her sort of 30s, and she's now in her 50s, and she's now noticing the memory is you know, more affecting her, in that she's having to use her diary and things like that more often. But she has had an impairment probably since not long after abstaining from alcohol. So that's an example where it's kind of longer term, but she hasn't really been progressing over that time. It's been pretty stable for her, and she's learnt ways of dealing with it. And I think that's the critical thing about identifying those people who are going to stay the same and the people who are going to get worse. The only way you can do that is with time and observation of those individuals. All right, so what we are going to just help you guys to understand some of the trajectory that people living with dementia also experience, and how MCI is related to that by the use of another picture slide. So this picture slide talks about something called the domains of dementia, which is a framework that we use to help people to make the diagnosis of dementia in primary care. But broadly speaking, it talks about changes that you might experience in your cognition And if you can look at the left-hand side of the slide, you'll see that those changes in cognition start very early, even before somebody experiences a diagnosis of dementia. And there's a little bit of function that's affected. And so that far column on the left-hand side is actually the MCI column. And you can imagine if you're having some changes with your cognition and a little bit of changes with your function, it could make you feel a little bit anxious, and it might make you therefore present to the GP with a bit of anxiety around not being able to do things as well as you were before, and not being able to recall things as well as you did before. And so it's us being alert to the fact that those might be the presenting symptoms of someone with MCI, rather than somebody coming in saying, I've noticed changes with my memory and I wondered if I could talk about it, because that really doesn't happen very often. They may actually be presenting with anxiety symptoms, or a loss of confidence, or a change in their wanting to go out and do things. They might be slightly more withdrawn because they've noticed these changes in their cognition and their function. And so that's what this slide is highlighting. And then Pete, do you want to talk through stages 1 to 3 briefly to show why this slide is so helpful at explaining the importance of making a diagnosis in MCI phase or stage 1?
Yeah, that's right. And this is a little bit more sort of trending into the sort of area of dementia, but Steph and I think it's worth talking about, particularly this concept of an early diagnosis, because you can see as stage 1 and 2 and 3 does signify a diagnosis of an Alzheimer's dementia. And as the time progresses, and that's often over numbers of years, the capacity to maintain your level of function and your level of cognition significantly reduces. And so the the ability for you to be able to do things that are still important to you may reduce as well. But in terms of like other things to remember about early diagnosis, we think about cognitive capacity. So, people wanting to have the capacity to make wills, to fill out advanced care directives, to be able to have meaningful conversations with their relatives, to be able to have early conversations about driving and where that might be heading, and eventually having to stop it. And these kind of important things for people in their life. And if you don't get onto it early, and the first time you're making a diagnosis of a dementia is in either stage 2 or where stage 2 is converting to stage 3, those opportunities are often missed. And in fact, people tend to be quite, there tends to be a lot of chaos in people's lives, which is depicted in that picture where all the lines are crossing each other. And you're probably all seen this, where the carers are throwing their arms in the air because things are getting way too hard to manage, and there's issues around safety, and the person living with dementia may be losing insight into their condition and maybe not taking care of themselves, or driving when they've been told not to, and that tends to be quite a challenging phase.
Yeah, so the messy lines on the right-hand side is a metaphor for life being a little bit messy at that time too.
Yeah.
And I've certainly in my career looking after people living with dementia, I've had some really positive experiences of making the diagnosis earlier on and having that time to prepare somebody for those later stages and changes, so that they actually, in fact, I had a lady last week who said, I've mentioned to my husband that I need to go and start looking at residential homes. And she's a lady actually in her early 60s, very well, still driving, still, living independently, traveling. They're going on a cruise next year. She's very far away from needing residential aged care, but she has the opportunity to go and look at places and make some decisions for herself, which she wants to take that opportunity to do that. And her husband was like, well, you don't need to go and do that yet. It's not the right time. But she doesn't want the pressure on her family when the time comes, and she wants to have had some choice. So that's the ability that we have by making that earlier diagnosis. All right, so we've alluded to some of them already, but there are several causes, as with dementia, where there are over sort of 100 different causes. There are also several different causes for MCI, and we've talked to a few of them. But on this slide, you'll see a brief summary of some of the other ones. So obviously at the top, we'll be thinking about Alzheimer's disease pathology, which I'll talk about on the next slide. Then there are the non-Alzheimer's disease causes of dementia, so frontotemporal dementia, vascular dementia, and Lewy body. And so somebody who has had, a long history of hypertension that perhaps hasn't been treated, effectively for one reason or another, may actually develop some small vessel disease and have some vascular changes that lead to some cognitive impairment, and before they experience a dementia associated with that. Then, as Pete mentioned, mental health conditions. So we know if people are depressed or anxious, they're going to have difficulty with their cognition. And medications that we prescribe. So there are a number of medications that we prescribe routinely in general practice that can affect cognition. So any one of the opiate medications prescribed for pain, or pregabalin and benzodiazepines, for example, are all going to affect cognition, as well as the anticholinergic medications, of which there are many, and they add together. So the more that you prescribe of those, the total burden increases. So sometimes they can only have a burden score of 1 or 2, but you might have prescribed 3 or 4 of them, and that together summative effect is quite significant. And finally, alcohol, as I mentioned before, and other drugs as well. So when we're thinking about assessing somebody with mild cognitive impairment, we're going to be thinking how many of these things are affecting this person's cognition. And I know obviously there may be more than one thing that might be having an effect. Now, thought it was important just to refresh everyone's memory about Alzheimer's disease, because as we said, it is one of the significant causes of mild cognitive impairment. And it's important to recognize that actually what's happening inside the brain is a formulation of these amyloid plaques, which are a buildup of a protein in the brain, which leads to activation of another protein called tau, which then causes neurofibrillary tangles. And it's the combination of these two pathologies in the brain that actually affect the neurons from talking to one another and leads to neurodegeneration and cell death. The thing about this is that the theory is that the amyloid starts to build up in people's brains from their midlife, but it sits there building up very slowly, about 4% a year, over about 20 to 30 years, until it suddenly is switched on by something. And I think we don't really know, it's still a little unclear exactly of the processes that lead to it being switched on, but it's important to recognize that this pathology has been there for quite some time, and that there's probably a preclinical phase of about 10 to 15 years of building up of this plaque that's happening. And so when we're thinking about some of the risks that lead to some of the dementias forming, it's important that we actually think about acting on those in midlife before this pathology starts to build up, because when you don't have any cure for anything like Alzheimer's disease, the best thing we have is prevention. So just bear that in mind. The reason why we talk about risk reduction in midlife is because the pathology starts in midlife. And there are now some ways of actually detecting the amyloid burden in the brain that, as Pete mentioned, there are a couple of blood tests that might become available in the next 12 months probably, and also a couple of PET scans, one which is just available in the research space, but if your patient has been seen in a research environment, then they may come to you to decipher that, which actually happened randomly to me about 6 months ago. I had a patient who came to see me. She had been to see a geriatrician in Melbourne and had had a scan that had identified that she had some she actually had an FDG PET, which is a glucose test looking at the brain function in terms of, you know, how different parts of the brain are metabolizing glucose. And the consultant said to her, I think there's a high chance that you've got a high risk of developing Alzheimer's disease. And then she came to me, and I had to decipher this test and refer her off to the local trials unit. So it does happen that people have what could be considered preclinical Alzheimer's disease. So she had the very mildest of mild cognitive symptoms, if any, I would say.
I think probably just also reassure people, Steph, that these blood tests and special scans are still in the realm of research or in specialist care.
That's right.
And
yeah,
they,
they're not in primary care.
Even though they're very, the specialists are very excited about them because there hasn't been a major change in understanding of being able to treat Alzheimer's dementia really forever, really. And there are now some drugs that can remove amyloid from the brain. So they're all very excited about this, but we're still really not sure about what it's all going to mean. The trials aren't yet conclusive. And you know, if you have a blood test that shows you might be at risk, we're still not quite sure exactly how to interpret all that. So I think another take-home message there is just be aware that this sort of thing is on the horizon, but there'll certainly need to be a lot of education put out there for us as GPs and educators before they become widespreadly used.
That's right. And that's why it's so important that we have a systematic way of approaching the clinical assessment of somebody with cognitive change, which is what we're going to step you through now. So these are the brief steps that we're going to talk about, or that you need to follow. And if you just have that in your mind, I mean, it's pretty straightforward, really. It's history, examination, investigations, and management in a nutshell. But there are just a few things around cognitive history that you need to be aware of, and cognitive assessment. So we're going to go into more detail about that. But to start that off, Pete, what exactly is cognition? It might help everyone to conceptualize how you think about cognition, and we'll do that with a little mnemonic.
Thanks, Steph. Yeah, so I guess when you're talking about MCI and dementia, cognitive decline or cognitive change is sort of synonymous with sort of chest pain and ischemic heart disease. So, you know, we're all really good at like thinking about how to ask a history about chest pain, and, you know, where is it and how long does it last for and what does it feel like and these kind of things. But we're being poorly taught, unfortunately, about how to do a history around assessing someone's cognition, which is the most essential part of this conversation you're having with your patients. And so we're going to go through that together now. Apologies for those of you who already might know it, and it might sound a little bit sort of medical student the way we're teaching this, but we know, and I know personally, that we're really, until I started doing this work, it wasn't really well taught to me either. So this is the mnemonic we use. We'll call it realms, and we're sort of divided thinking about cognition into 6 large areas. So the first one is recall and memory. So I've talked about that. So that's about asking someone, you know, how's your short-term recall going? So are you remembering conversations from this morning or from yesterday or from last week? Are people needing to remind you about conversations that they've had? And you're trying to get this history from the person, but of course, if their memory is affected, then they're not going to give you a good story. And so you also want to get a collateral history from their carer or partner or someone who knows them pretty well. And you're trying to get a story that's happened over time. So this isn't something that we're looking at that changed yesterday or last week over minutes. This is something that's happened gradually, that's come on gradually over months to years. So gradual onset over months to years. And we find that the long-term memory, while in the later stages of dementia may eventually be affected, in MCI is generally always preserved. So they can remember, you know, what sort of job they did when they were younger, and, you know, birthdays and those kind of things. But perhaps what they ate for dinner last night or what they did yesterday might not be so, might be affected if they've got the amnestic version of MCI. And what about executive function, Steph? What do you ask? What does that mean, and what do you ask?
Yeah, so I kind of think of this as your planning, or your, how do you go about organizing things? And so, in fact, I ask just that. So I sometimes ask, and that's how I was taught, actually. I ask, do you have any occasion to plan anything, like plan a holiday or organize things like going on a trip, a small trip? So that could be like packing your bag, or it could be arranging the tickets, or it could be arranging to meet people along the way. And that gives you an understanding of somebody's executive functioning, so their ability to think something through. Or it might be around somebody who's always been very handy with cars. I had a guy a few weeks ago who would take apart a car and put a car back together again, but he was having some difficulty in putting the car back together again, and his son was having to guide him with the steps involved. So that's evidence that he's having some problems with his planning and thinking and getting things done. So
yeah, that's another important principle, that you need to find something that's specific for the person in front of you. So if they said, "Oh, I never plan the holidays," "Oh, what about going shopping?" "Oh no, my wife does all the shopping." Sometimes you go down the list of all the things in your head that you normally ask, and it's it's not done by that person sitting in front of you. So yeah, thinking about hobbies and sort of is often a good way of doing that.
Yeah, or just asking. I sometimes just ask people to tell me what they do. Tell me a bit about you and what you do in the week and what sort of things you get up to, so that I have a clue as to what they're interested in, rather than asking lots of questions about things that they might do. Sometimes you have to go through a whole list, but generally people have a hobby or a something that they do. So
generally, yeah. And then attention is about what you're hopefully doing right now, and staying focused, and laying down the memories of what we're saying to you. And someone who has issues with attention doesn't have that capacity, but they also, you might find that they're just not as good in crowded situations where there's lots of stimuli coming in from them and different noises. So there might be background noise from music or background noise from a crowded place. And they find that their ability to maintain attention in that sort of situation is less. And that's a good thing to ask too, like whether you've been, how are you, going out for dinner, or how are you going out in social reasons? And if they say, "Oh, I don't like doing that anymore," trying to tease out why it is that's occurring. And it might be that they just can't seem to deal with all the stimulus coming at them at the same time.
Or watching the footy, are they able to watch a whole match of footy and still, follow on what's going on, or other TV programs? That's another.
Depends whether my team's winning or not, Steph.
Yeah.
And then language is the next one, and language has got multiple components to it. So dysphasia is about your ability to comprehend and express yourself. You might also have like a dysarthria where you're sort of slurring your words. And I was just thinking earlier when Steph was talking about alcohol and drugs that some of my patients have been on really high doses of methadone, and when they take it in the morning and they see me half an hour later, their words are slurred, which is that's a form of a language cognitive impairment from a drug. So so it could be that, or it could be an agnosia, which is the one that most people know, which is around just not being able to name things, or not just, but not being able to name things. And we're used to that because we're often asking that if we're doing a mini mental state examination. And you often find that people try and use words to describe the thing that you're asking them to name, but they can't actually find the word. So you might hold up this and say, if you can see that, that's my phone coming in and out. What's this? You want them to say, "Oh, that's your mobile phone." They go, "You know what that is? That's the thing that you use to talk to people too." So they find other words to try and describe for the actual word that you want them to name. And then there's motor functional dyspraxia. So Steph, what's that?
So the use of objects really. So I asked people about, are you having any issues with using things like the remote control or your phone, for example, navigating the different apps on the phone, or using the computer, or those kinds of things. So, or it could be using objects appropriately. So using tools, for example, if somebody is, doing a lot of work in the shed or something, are they able to use the right tool for the right job, and use it appropriately, or using the vacuum cleaner? So I had a lady who she'd been to see several people, and they didn't feel able to make the diagnosis. But one thing that she said she couldn't do, or she'd been in a holiday house that wasn't her own home, and she couldn't work, her daughter said she couldn't work out how to plug in the vacuum cleaner into the socket. And okay, so she was in a different environment, but sockets are the same everywhere. And that was something she was really struggling with. So it's about, it might be an unusual thing that somebody has. And also it was at the time of the, COVID, and you had to, show your thing to pass to get into everywhere. Do you remember when you had that, like, COVID pass?
You just had some agnosia there.
QR codes. You had to QR code everywhere.
That thing you used to get into things.
Yeah, you had to QR code, and she couldn't get the hang of it. She kept using her cash card on all those QR codes because she didn't know what it was. So
and then
it can be quite subtle. Like
that thing about the vacuum cleaner is interesting because that includes another realm of cognition that we haven't got listed there, which is visual spatial. Maybe we should have 2 S's. We should have realms, and we can have visual spatial. Yeah, because if you think about the putting in the plug, there's like the 3 different angles of
which way you go,
which way you're going, and so it might have been a visual spatial cognitive impairment for her. But the last one is social, and that's around sort of becoming withdrawn, or having some behavioural disturbance, and not being able to sort of follow normal social cues that we'd expect of someone.
So those are the sorts of things you might ask about, and that's the kind of how you conceptualize your history. These are the things I want to ask about. But it's also really important to listen to what the person is saying back to you, because some of the realms of cognition will actually, you'll be hearing them rather than asking questions about them.
Or if I was going to be, if I was testing a medical student, I'd say some are signs and some are symptoms.
Yes, that's right. So, I ask people questions specifically around memory, but then I might ask them something like, oh, do you read the newspaper, or do you watch the news on the TV? Can you tell me anything that's happened recently in the news or on the newspaper? And if they give you quite a vague answer, or they say, oh, there's that big war that's happening, but then they're not able to give you any detail, that's a clue that they're not able to retain that information. They've got a sense of something that's going on, but they can't be specific about it. So it's important to listen for those sorts of things. And also, whilst you're listening, if they're in the room with their collateral, the person who's going to give you the collateral history, keep an eye out for any subtle signs that they may be giving you, either eyebrows or looking different directions, about perhaps the story that you're hearing from the person is not as accurate as you think it might be. So that's really important as well. And then regarding language, it's really interesting to start having a listen to people's language. So if they start talking a lot, but they don't seem to be saying much of any detail, which goes back to the thing about the news item, that's another clue that there's a problem with their language. Or some people will stay on the same topic, very comfortable on a topic that they know lots about, but when you start to try and get them off that topic, that's when you start to notice more deficits. Or actually asking people to name objects, which is something that you'll see we do when we do use something like the mini mentor. When you ask people to name a pen or the watch, those things are quite simple items. But if somebody's perhaps got their phone in the room and you ask them, well, what do you call this? And there's a way of kind of challenging their language in the history taking. So that was really what I wanted to say about that. Just remember to listen. Or the other really important clue is, if you ask someone a question and then the response you get isn't quite what you're expecting, or it doesn't seem to be that they answer the question appropriately, that can be to do with attention as well. But equally, it might be to do with their hearing. So it's important to repeat the question and just make sure they have understood what you were saying. So Pete, what are some of the words you might use to, because as you said, none of us have had any teaching specifically on this, so it can be hard to get the right things in the frame of mind about how you might actually verbalize some of these questions.
Yeah, no, I think it is. And so I normally use some broad principles are to just have a think about the person in front of you and whether they and if they're aware of what's going on. So if you're going to inquire about someone's cognitive, their cognition, then you kind of really you should tell them that that's what you're going to be doing, because otherwise people get a bit sort of narky with you about, inquiring about their, what they're able to do. And so you do need to get that form of consent and sort of make your wording a bit around that. So, a common phrase that I use is, are you having any difficulties or challenges with your memory or thinking? Now, sometimes that's a good trigger and people say yes, and they give you a story. Or sometimes people just go, no, it's fine. But I'm worried because I've seen evidence through my observations or through their carers giving me some information. And then it gets a bit more tricky because they've kind of just said, no, I'm fine, as in full stop, exclamation mark, let's move on. But you as the clinician kind of want to inquire a bit more. And so then I do kind of what Steph has been doing, and I kind of take a back seat a bit and go, yeah, no worries. Well, so how things been going? What have you been up to? How you can be keeping yourself busy? What hobbies are you doing at the moment? I can't remember. How's your garden going? You're still driving. These kind of questions. And so really you're sort of asking about function and how their cognition might be affecting their function. And that's the way I kind of do it. It tends to be sort of quite an easy way to sort of get into that conversation, because some people can get very defensive when you start asking this stuff, particularly if they're not the person who's worried, or they might not have any insight. If they've come to you themselves and they've said, oh, I'm worried about my memory or something part of their cognition, that's a different story, and it's a lot more straightforward in terms of taking a history. That's what I find. Yeah.
I think the other thing is normalizing it, so or destigmatizing it. So start asking people routinely as part of perhaps your over 75s care plan, instead of just doing the mini mental state examination, which is usually what is done as part of the over 75s check. Phrase it before you do that, so we're just going to ask you a few questions about your memory, but I actually just wondered, have you had any worries about your memory? Have you had any concerns? Is it okay that we ask you a few more questions about that? Because it's good to stay on top of looking after your brain, like it is important to stay on top of looking after your heart. And so we're just asking everybody these questions now, so you make it that you're asking everyone that, so it's not them particularly that you're asking. I mean, it might be if they've come in about that, but you just want to start bringing it more into routine conversation. It's important to know about your social, psychological health, and as part of that, I also need to know about your cognitive health. So I'm going to be asking you some questions about your cognition. Is that okay? And I think that, rather than I'm worried about, we want to ask about your memory, because it is broader than that. You want to keep it broad, and you want to make the person feel like you're interested in them, because we are interested in them. And then we also want to do it for their benefit, because the benefit of knowing is that you can actually help people feel less worried about those symptoms. So it's all in the kind of the broadness and, I guess, the pitter patter of making sure that you have a good good style of communication with your patients so that they feel comfortable to talk to you about their concerns. They feel listened to. So that's how I kind of approach it. But on the screen there, you see some useful things to jot down if you need any tips. So function, Pete, whilst we said it's minimally affected in mild cognitive impairment, these are the sorts of things that we might ask about.
Yeah, I think we sort of covered this. You know, the main take-home message is if you're concerned that maybe this is more likely to be a dementia type syndrome that you're looking at, you're trying to tease out a change in function over the last 12 months. So the sort of questions I ask are, have you noticed any change in your ability to do stuff over the last year? Or was there anything you were doing 12 months ago that you stopped doing now? And again, the story is often best told by the carer or the spouse or whoever's you're getting the collateral history from.
Yeah. Or sometimes I ask, how do you divide the roles in the household? Who does what in the household? And has that changed? Is somebody doing more of something than they were before? Because everyone has their set routines usually. And then it usually comes. And that might be an easier way rather than the carer saying, oh, no, I do everything. So if you say, oh, how do you divide the roles? And the person with the cognitive change says, well, I do all the cooking. And then that allows the carer to say, oh, well, I think I do a bit more of the cooking now, rather than them feeling like they're saying, I do all of the cooking. It's just a way of, making it easier for people to talk about, because it's hard for couples particularly to have that conversation. All right, so cognitive assessment tools. Pete, do you want to run us through the cognitive assessment tools and which ones we might choose to use? I've only put a few up here today.
Yeah, sure. So there are many you can use, probably for 5 or 6, and a lot of people are used to the mini mental state examination because that's embedded in most of our practice software, and it's probably what we did when we were working in hospitals. But you have to have a good level of education to be able to do the MMSE, and so it's not suitable for all of our patients. And so there are other ones that are certainly the geriatricians like, and I think are actually better than MMSE. So up there is the MOCA, and that uses a lot of visual spatial clues as well, and some more stuff around language that doesn't involve spelling the word world backwards, which is good. Like you might ask someone to name as many animals as they can over the space of a minute, and that can give you lots of good information about speech. And there's also the RUDAS, which is for people of a non-English speaking background. I use the GP Cog, which is not listed up there because that's specifically made for GPs. It's fairly quick. It involves a clock face, which is on the screen there too, which gives you lots of information about planning and visual spatial cognition. And it also gives you a prompt to get a collateral history if the score is intermediate. So they're probably the main cogs. And then the other one, if you're working in the Aboriginal health sector, there's the KICA, there's a urban and a rural one. And it doesn't matter which one you do, but you need to be trained so you know what you're doing when you're doing these tests, and you need to, again, make sure that it's appropriate for the person sitting in front of you. And I'm not sure what the next slide is, Steph.
It's talking about investigations, but
investigations,
before we go
okay,
on to that one, what would be a score that would tell you that somebody has a mild cognitive impairment of a mini mental or a MOCA?
Well, I would say that's a very good question, and it's hard to answer that because these tests aren't actually diagnostic. So there is, even though you might say, you've read that, in a mini mental state, when the score's less than 25, there's a likelihood of cognitive impairment. It doesn't say you have dementia. It just says that you've been challenged enough on the scoring system that there's been enough mistakes made that there might be an underlying cognitive impairment. So they're not diagnostic. They're just there to basically give you objective assessment of someone and to try and assist you in making your diagnosis. So, you know, unfortunately, you know, you can have false positives where they might score very highly, and yet they might be cognitively impaired because they've been practicing it, because I know they were coming in and having to do it, and they're got a high IQ. Or it might be a very low score, but they don't have any cognitive impairment because they were so nervous they couldn't remember anything, and their attention skill set was not good. So I don't use so much an exact score, Steph, but more I actually like doing these myself because I like watching someone do the test. So I particularly like doing the clock face drawing when I'm doing my GP cog, because it gives me lots of information about that person rather than just the number itself, but actually how they're actually performing.
So does the on the top of the mocker, where you've got that's a mini version of the Trail B test on the left-hand side of the mocker, and you have to draw from number to letter, going up to from beginning to end. And quite often, if somebody's got a cognitive impairment, they will start doing it, and then they will sometimes forget what the next step is. They'll sometimes ask you for clarifying questions. They'll say, am I supposed to be doing it this way? What was it that you said? Or, oh, this is quite tricky. And so just the observation of somebody performing the cognitive assessment is really interesting. And yesterday I saw somebody whose daughter had been present when her mum had been completing a version of this. So she had to do a cube and do a clock face. And the daughter said she was very, very shocked and surprised that her mum couldn't draw a cube or do the clock face. So sometimes for family members, it can be really an insightful thing as well. Like, it can be quite confronting for people, but when they have thought that their parent or spouse was managing, appearing to manage quite well, if you can't then draw a cube or a clock face, that demonstrates that there are some significant changes in somebody's cognition, and sometimes that can actually make them more aware that that person is actually really struggling with things that they didn't anticipate that they were struggling with before. So
I think the other quick tip too is that now you're aware of the different realms of cognition, is that's how these assessment tools are actually designed. So they actually go through those different areas of attention and recall and visual spatial and language, and they slowly work through them. And some of them are more lean to one type of to some areas of cognition, and some of them more sort of well-rounded to other areas of cognition. But that's how actually these tools have been designed. And for someone who has an amnesic MCI, often what you'd find is that they really struggle with like immediate recall questions, but all the other parts of their cognition that are assessed, like the visual spatial or the maze test, they're fine. But when it comes to remembering 3 objects, 2 minutes later, they can get 1 or they get 0 out of 3, but everything else is completely fine. So that's another helpful tip to understand how these tools are created and how it might look in an amnestic MCI.
And sometimes that can give you clues when you get the results of the test. So specifically for the mocker, I think there is something about I can't remember the exact detail, but the reason why it asks you the 5 words and then asks you them and gets you to do a category cue and a multiple choice cue, even though you don't score any points for that, the category cues and the multiple choice cues, if they actually remember it, but based on that, then that's more likely to indicate that some of their memory is intact, and that corresponds to a specific type of memory recall. So it is kind of quite a sensitive test for memory, the mocker, because it's testing lots of different aspects of memory, not just short-term recall. It's testing whether it's cued as well. So when we're examining somebody who has MCI, we want to be assessing their overall well-being, but we want to be also thinking about what could be some of the risk factors or some of the things that might indicate that there are other things going on. So we want to check their blood pressure, see if they've got any pre-existing history of diabetes, because we know that diabetes increases your risk of developing vascular changes, and assessment of weight, which can be really helpful to tell you, you know, is this person a frail person? Are they eating well? You know, are they perhaps not cooking as well as they should be, and therefore their nutrition is suffering? And so, you know, general assessment of how well they are. And then a brief neurological examination can give you lots of information as well as to whether or not perhaps that person has another illness such as Parkinson's disease or motor neurone disease or something like that. And then investigations, which I'm sure most people are familiar with. These investigations are the routine ones that we do for cognition, and basically we're looking for any reversible causes. So obviously somebody who has a high calcium, I remember from medical school that we used to nickname that moans, bones and psychic groans, because a high calcium can cause all sorts of problems. So thinking about, you know, are people's electrolytes normal? Do they have normal levels of vitamin B12 and folate? Are their thyroid function tests in range? And if they're not, correcting those things, because correction of those things may actually improve their cognition. And so these people might be experiencing a temporary MCI as a result of changes in their biochemistry. And why do we do a CT brain, Pete, rather than an MRI scan?
Well, because they're you can bulk bill them, so they're inexpensive. Well, generally they're less expensive, and what we're doing there is excluding other causes, or excluding causes of the cognitive impairment. So we're not trying to diagnose dementia. You can't diagnose dementia with a CT brain, but you can potentially pick up a chronic subdural hematoma or the beginnings of a brain cancer. Or, you know, hydrocephalus, something like that may be causing cognition. So they're the things you're trying to exclude. And I mean, if you can do an MRI, that's okay. But again, we don't have eligibility on the MBS to do these sorts of scans.
All
So
right.
Yeah.
So we've done our investigations. We've got everything back as far as we know so far. And how are we going to explain to the person in front of us that we think they've got MCI? What are we going to say?
Yes, but we're trying to avoid the words "it's only mild." That'd be one of the take-home messages. But so look, I think you know, GPs are pretty experienced at giving significant news to people, and I think, you know, seeing the context, people, you know, you've been open to someone. We're making this assessment on your cognition, and you've done blood tests and CT scans of the brain and cognitive assessment tools and stuff. So, you know, like it's not something that suddenly comes out of the blue, like I'll present with a lump, oh, we better do a biopsy. Oh my goodness, that's a cancer. That was really unexpected. It generally doesn't sort of roll like that. So that's one thing to remember, is that it's not generally that sudden in terms of unexpected. But you use the general principles of giving any sort of significant diagnosis. You're open, transparent. You say, from everything I can see from today, we can't really find any other reason why your cognition is impaired, like your memory. And that means that we're left with this condition that's called mild cognitive impairment. It doesn't mean that it's mild on you. That's just the term that's been phrased. But it means that you do, you know, I acknowledge that you do have an issue with your memory and that does exist. But what you're telling me is that you're still able to do things you want to do in your life. Your function's still preserved. And then I'd take a pause and let them go from there and let them ask their questions. And through that conversation, I would make sure that I'm pointing out that, and they'd probably ask that this is not a dementia, but that, and most people, 60% of people will stay the same or they may improve. But there is a number, about 10 to 15% a year, who will progress to a dementia. And so it's important that I keep a close eye on you. So I'm actually going to put a recall in my system here that we're going to have a chat about this every 6 to 12 months. And that might be me asking you these questions we did again around, the GP cog I did with you, or it might be you just having a chat to me about how you're going, or maybe getting your partner in here and having another chat. But it's really important that we keep talking about this together. And the other thing that will make a difference to this person is to make sure that all of their other chronic diseases are well cared for, that you're looking at their blood pressure and their diabetes and their other vascular risk factors that Steph just talked about. And that probably wouldn't do it at the first appointment, because that's a lot of information I've just given someone just over in 2 minutes. That's obviously going to take more like 10 to 15 minutes. But then I would get them back at another time and would start going through some other stuff. So I'd say things like, look, we talked about the other day how your memory isn't as good as it was, a few years ago, but just you're still able to do things. That's really cool. Now's a really good time that that I just ensure and have a chat to you to make sure some things are up to date that may be important to you. So, for example, is it important for you to have an up-to-date will? Or is it important for you to have an up-to-date advanced care plan, and explaining what that means? And so again, that's the sort of thing that would happen over multiple visits. That's the way I do it, Steph. Is that a good answer for you?
Yeah, and I've just flicked up the, I skipped ahead. I'll go back to the slide before this, but I just wanted to put this slide on, which is the MCI checklist, which we've collaboratively worked with another organisation called Face Dementia to create. And this gives you the sorts of things that you might consider talking to people with MCI. It says 6 to 8 weeks post-diagnosis. This is ongoing, I think. This is not something that you're going to do within 6 to 8 weeks, or at 6 to 8 weeks specifically. This is just the sorts of things that you need to be thinking in your mind when you're addressing this, like you would with any other chronic disease. What are the sorts of things I need to think about when I'm seeing this individual? So it's, what are their goals of care? How can you maintain them living well? Education, because it's a lot of information and there's a lot to go through, and sometimes that has to be repeated because there's so much to talk about. Thinking about those risk factors, what can we do to reduce the risk on the brain going forwards? Reviewing those medications, and as Pete said, legal planning, and potentially arranging a GP management plan to help with allied health and other supports. And on the previous slide, I put just some initial simple things that you might want to do. That Dementia Australia actually run a program called Mild Cognitive Impairment Thinking Ahead. This is a national program, small group sessions supporting people with a new diagnosis of mild cognitive impairment. A lot of it is health education and advice, and might involve explaining to people about those compensatory strategies, the importance of routine and social interaction. So it's well worth finding out about your local one of these groups that's running. I think in Adelaide they run about 3 times a year.
I think the other question, Steph, that people often ask is, is there anything I can do to making sure that it doesn't become a dementia, or get worse?
Yes, so we're gonna, these things are the things you can do.
Yes, exactly. Yeah. So my answer is yes, there's lots you can do actually. And they might already be doing them. And if they're not, it's a really good time to reinforce them. And they're just the simple things that you're talking to your patients about all the time. But geez, you've got a really great hook for motivation to get some behavioural change now. And they're things like getting half an hour of exercise every day, making sure that you're engaged socially. So that's a really important one, being socially engaged. So that might be making, hanging out with your family more. It might be going to a local support group, or down to the men's shed, or maybe to the bingo, or whatever it is in your community or town that people do socially, making sure that that person stays connected. Because we know that exercise and being socially connected are 2 things that can significantly slow down a progression of someone who's developing a dementia. So both in the MCI phase, but also in the, if they actually do go on to develop in the sort of stage 1, stage 2 phase of their dementia. So they're the things I sort of harp on about. And then in the back of my mind, I'm just making sure, we talked about their comorbidities, and that we've reviewed their medications. We talked about earlier, Steph, around anticholinergic drugs, making, if they're on multiple medications, maybe getting a pharmacist to have a look at their medications for you. It's never too late to stop smoking. And alcohol is another really big one that Steph and I always yarn about, because we seem to share, or not share, we have patients that we both have that where alcohol is a big contributing factor to people's cognition. And so that's probably a whole session in itself, a whole talk in itself, but trying to get people to reduce alcohol when they have cognitive impairment can certainly be challenging. And sometimes you need to get some help from specialists and some tips and that kind of stuff. But at other times, people are very willing to cut back their drinking once you've got this diagnosis.
Yeah, sometimes it's a helpful motivator.
So I guess the take-home message there is that they're things you're doing already.
Yes.
It just gives you an opportunity to really reinforce them with a really good behavioural hook, motivating factor. We don't want this to progress.
And it doesn't have to be just you that does that. So it can work as a team, so involve other people in your practice. When the practice nurses can be really good at providing some of that backup health, reinforcing that health advice. And then also other allied health professionals. So exercise physiologists, for example, can help with motivation to get people back into exercise. And certainly in our local area, there are lots of other programs. And I think the health pathways will probably put you in contact with other organisations that offer some of those support structures as well, that can get people socially engaged. And sometimes it's the councils. So just trying to use as many, you don't have to find out all of the information for yourself, because it can be quite overwhelming trying to think about all of that. I just wanted to put one slide on here about driving, because I thought it was interesting that Ausroads made an update to the driving standards specifically around MCI last year, and also added in a little comment about preclinical dementia. And I just think this reflects the changing, or the relevant importance of MCI now within our world as primary care practitioners, that we do actually have to be cognizant that this is coming from different directions. So what they actually stated in their documentation is that there have been studies that have shown limited evidence that MCI actually affects driving. There wasn't really an increase in error rates in people with MCI who are driving, but those people who have multiple domains affected, so thinking about those multiple domains of cognition affected, it might be appropriate for them to seek further advice. So whereas with a dementia, certainly in South Australia, there's mandatory reporting, and you can't hold a conditional license according to the Ausroads guidance. With MCI, that isn't the case, but we do still need to be alert and asking questions about people's driving, because it might be that that person has significant impairment in their visuospatial cognitive function, for example, which then might actually affect their driving. So it's something that we do need to consider. And they also had a little statement about preclinical dementia. So thinking about that lady that I had who had a test that's identified that she's got some amyloid in her brain, but she doesn't really have any symptoms, she'd have what you'd call preclinical dementia. And those people can still hold a conditional license for driving because they haven't got any symptoms of cognitive change. So it's really important that the history is still, that clinical assessment is still the #1 priority. And this is just a note to mention about the different, I've already mentioned this, but the different health professionals that we can additionally use as part of a GP management plan to support people, because they do need ongoing review for their mild cognitive impairment or dementia. And finally, the resources that I just mentioned, these can be some helpful resources. So Forward with Dementia. There's also a guide on Dementia Australia website about managing MCI, which I cross-referenced all of the information that you've heard today, so you'll see it duplicated there. And the take-home messages, Pete.
Well, hopefully by now people are aware of the new term, Steph, and
Yes.
they'll remember to that figure about 10 to 15% of people will progress to a dementia, so that can be a useful number to remember. And that there's lots of things you can do to help slow progression, and the early diagnosis makes a big difference. And and it's important.
So do we have any other questions?
Not
Does anyone have any
at
questions?
the moment, but now's the chance.
I'm just going to stop sharing, and we'll wait a couple of minutes to see if there are any questions. I would suggest having a look at your health pathways, because I think it was last year, I worked for Health Pathways down in South Australia, and there was a national program to put lots of information for consumers for advice about local supports and organisations that can help people with cognitive impairment. So I think that's probably what's available through your PHN.
I'd put a pitch out for Forward with Dementia. That's not a website that many people know about, and it's not as the website itself is much smaller and condensed compared to Dementia Australia, which has got just about everything on there, which is good and bad because you can get a bit lost in there. So Forward Dementia, it's got some really good stuff around, you know, the new drugs that are coming out and what are the trials showed, and those kind of stuff. So yeah, have a peek around that. I think you'll find that quite informative.
There is a question about the new medicines. Somebody put
Are there any new medicines that can slow down the symptoms?
So there's 2 medications that are still in trial, and one of them is now being prescribed in the United States of America, and this medication is an anti-amyloid medication, which is a monoclonal antibody, and there are 2. One of them works on the amyloid plaques, and the other medication works on the neurofibrillary tangles. So they work on different aspects of the amyloid pathway, and they go around essentially dissolving the amyloid and reducing the amyloid burden in the brain. The theory that the studies showed was that over an 18-month period, cognitive change slowed in the population who were using the medication, so that there was an 8-month improvement, which meant that after 18 months, both populations declined over time, but the population who used the medication declined 8 months slower than the other population. Now, the studies are only over 18 months.
That means you're slowing down time, Steph. That's a bit of a mind boggle.
I know. I don't know if I explained it very well, but basically what
No, you did. I'm just teasing.
It was reported in the print media as a 30% reduction in symptoms, but in reality it's 8 months difference in functional change, if you like, on a scale. Now, it's only an 18-month trial, so what the drug companies say is that they would anticipate that might even get wider, you know. But what we know is that it doesn't stop decline. Both groups still decline over time. So as yet, there's no truly disease-modifying medication available. What they have identified is that the earlier you give these medications, the better. And so that's partly why there's more emphasis on diagnosing people with mild cognitive impairment, because if that drug became available in Australia, you would want to be targeting it at the right people, which would be the people with the most mild symptoms. But it's not available yet. And unlike, I would say is unlikely to be available, something that's available on the PBS, I think in America it costs quite a bit of money. Yeah.
Any other questions? I think that's just about it, Steph.
Perfect.
Good job.
All right. Thank you for joining us.
Great, thank you. I'd just like to take this opportunity to thank our speakers tonight. We'll be following up with an email, and I'll make sure that the consumer resources that have been developed by both PHNs are available via that resource. There'll also be just a post-event evaluation survey, which we would really encourage you to fill out. That would be fabulous. And yeah, and the connections to the health pathways, we encourage you to please have a look at them. They've got a lot of valuable information that can help you in practice, and also we welcome any feedback regarding those pathways. So if there aren't any more questions, then yeah, thank you and have a wonderful evening.
Thank you.
Thank you.